Good afternoon, everyone. I'm Dr. Kim Newell-Green, and I'll be the moderator for today's virtual grand rounds, which is entitled Opioid Treatments, Practical Guidance for Clinicians. Before we begin, I'd like to acknowledge the CDPH as our very strong partner in providing relevant public health education for physicians and other healthcare providers in California. With California's escalating opioid epidemic, all clinicians should be well-versed in treating patients with opioid use disorder. Now, with naloxone available over the counter, everyone can be empowered to reverse opioid overdoses. But how many of us are comfortable prescribing buprenorphine, referring to methadone treatment, or using naloxone? We're thrilled today to have Dr. Marlene Martin to help educate us in using these important and life-saving medications. Additionally, we're very happy to welcome Dr. James Watt, who will present updates on COVID-19 and the current status of vaccine recommendations for the fall. Next slide, please. Here are our speakers' disclosures. Next slide, please. And here is our agenda today. Next slide, please. Just a reminder that this series is accredited for CME credit, and I'm thrilled to note that this virtual grand rounds may be applied to meet the one-time 8-hour MATE Act training requirement that physicians need to get their DEA certification this year. You will be sent a survey after the completion of the webinar, so you've got to attest your attendance, and then once you complete that, we'll send out the certificates. First, and getting into it, we'd love to welcome Dr. James Watt for our state epidemiology update, who's coming in the place of our usual presenter. Dr. James Watt is the Assistant Deputy Director in the Center for Infectious Disease at the California Department of Public Health. Thanks so much for being here today.
Thank you, it's my pleasure. Can we have that next slide, please? Great, and the next one. All right, so I'm gonna just briefly go over respiratory virus trends with you, focusing on the big three viruses, SARS-CoV-2, influenza virus, and respiratory syncytial virus, or RSV. I'll share with you some projections, both from CDPH as well as the CDC, about what we might expect in the coming couple of months, and then close with a quick note on vaccines and treatment. Next slide, please. So here's the bottom line with regard to disease activity right now. COVID-19 activity is moderate and decreasing. Influenza activity remains low, and RSV activity is low, but we are seeing some initial increases. Next slide, please. So let me share with you a few figures just to illustrate those disease levels. This is from our statewide dashboard. You can see on the left-hand panel new hospital admissions. Those peaked right around the end of August and have been coming down over the last month or so. However, we're still seeing about 300 new daily admissions for COVID-19. With regard to deaths, those have plateaued, and we're seeing about 18 deaths per year. So still a fair bit of mortality from COVID, although not as high anywhere near as what we have seen in the past. And then test positivity is decreasing and is now down to about 8% from a peak of about 14% 4 or 5 weeks ago. Next slide, please. This figure shows our wastewater data. You can see that most of the state is in the yellow color, which indicates moderate COVID-19 activity. The northern part of the state is still in the high level, although we don't have a lot of data from the north, so those data are a little bit unstable. And then the line graphs on the right break down the state by region, and you can see declining declining SARS-CoV-2 concentrations in wastewater across all the regions in the state, with most regions in that moderate zone. So still a fair bit of SARS-CoV-2 out there circulating, but coming down. Next slide, please. This figure shows a test positivity for a variety of different respiratory viruses that we track. And I'm just going to pull out a couple of these pieces of spaghetti for you to highlight where we are with those three viruses. So the heavy red line there represents SARS-CoV-2. You can see that that peaked right around the end of August and is coming down. The dark black line is influenza, that is low, and just the yellow line that's picking up just a little bit in the last week or two represents RSV. This is an early increase, and it's similar to what we saw last year. If you look back on the left-hand side of the graph, you can see October 2022, and RSV picked up and peaked right around the end of November, early December last year. We don't know what it will do this year, but it looks like it may be in that similar trajectory. Next slide. This graphic shows emergency department visits for the three viruses or the three diseases. You can see that we are seeing COVID-19 driving the ED visits for these three diseases and coming down over the last few weeks with RSV and influenza low. Next slide, please. Okay, switching to projections, what are we looking to see in the next few weeks? These are some projections from the California Department of Public Health. We take several different models from around the country and sort of consolidate them to create a single view for the next few weeks. On the left-hand panel, you can see forecasted hospitalizations for COVID and influenza for the next several weeks. You can see that they peaked several weeks ago. They've been coming down, and we're projecting that they will continue to decline for the next few weeks. And then the individual models are broken out on the right-hand panel. You can see those shaded colors there, which represent kind of the different prediction intervals, with the heavy lines being our sort of consensus model for the next few weeks. Next slide. And this is a forecast from the CDC that looks a little bit longer out. So the CDC has been trying to estimate what we can imagine for the peak level of hospitalizations this winter season. And the bottom line is that they are forecasting somewhere between what we would see for a severe flu season and something similar to what we saw last year with the so-called triple-demic, where influenza, RSV, and COVID all kind of peaked around the same time. So let me break down this figure for you. There's a lot going on here. The y-axis is the peak level of hospitalizations during the season. And then you can see those horizontal lines that represent three different benchmarks. The lowest one is the 2017-18 season. That was our last severe influenza season. The middle line is last year's winter peak, and the top line is the previous year, 21-22 winter peak. CDC has two different scenarios here, one that based on a sort of moderate flu and RSV scenario A, and scenario B is a more severe flu and RSV season. You can see that both scenarios fall between a severe flu season and last year when you add in COVID. And the key points here are that during the pandemic, we saw significant changes in flu and RSV patterns. CDC expects those to be more normal this year. We do expect peak hospitalizations to be higher than pre-pandemic because now we're dealing with a third virus. And then there is substantial uncertainty here, which may be affected by what happens with COVID-19, whether we see a new variant that is more severe or has more immune escape, if influenza is more severe than expected, and also how the timing of these peaks overlap. But the point is that we should expect to see peak hospitalizations above what a pre-pandemic severe flu season, and could be as high as what we were seeing last year. Next slide, please. So now is a key time to take action to mitigate these impacts on the healthcare system and to protect individual health. And some key messages on vaccines. Now is the best time to get them. Influenza and COVID, the messages really line up with everyone 6 months of age and older needing a dose of influenza and COVID-19 vaccine. And then for RSV, persons 60 and older should discuss with their providers. We do have a new product for infants, nirsevimab. All infants who are 8 months of age and less during the RSV season should get a dose of nirsevimab. And pregnant women can also be vaccinated at 32 to 36 weeks gestation between September and January. And if they are, then their infants should be protected and would not need nirsevimab. Next slide, please. A couple quick resources here. If folks are looking for vaccines, they can look at myturn.ca.gov or vaccines.gov. Next slide. And a quick reminder that if you have high-risk patients for more severe disease due to COVID or influenza, that antiviral medication, should they get sick, can help to prevent more severe disease. And so please talk to your patients about a plan for treatment during this season if they do get sick. Next slide. And here are some resources. You can find these in the slides afterwards for folks who are interested in testing or treatment. I believe that is my last slide. Thank you very much.
Thanks so much, James, for joining this month. Helpful for us to have a view of the winter as much as you can predict with your crystal ball. Now, I'd love to introduce Dr. Marlene Martin. Dr. Martin is an associate professor at UCSF and a hospitalist at San Francisco General Hospital, drawn to medicine to address health inequities and social injustices. Her interests lie in system improvement and innovation with a focus in addiction, community partnerships, Latinx health, and care transitions. Marlene is board certified in internal medicine and addiction medicine, and she founded and directs the Addiction Care Team, an interprofessional consult service that provides compassionate care focused on harm reduction, evidence-based treatment, and linkage to care for hospitalized patients with substance use disorders. She's also the Director of Addiction Initiatives for the UCSF Latinx Center of Excellence, where she aims to improve the health of Latinx individuals in San Francisco affected by substance use disorders in collaboration with community-based organizations and community health workers. Thanks so much for being here today.
Thanks so much for that lovely introduction. I'm really happy to be here to talk about one of my favorite topics, opioid use disorder, and what we can do as clinicians. Next slide, please. Our objectives for our time together are for you to walk away from this talk being able to describe the urgency of our overdose crisis, to understand that buprenorphine and methadone are highly effective, evidence-based medications for opioid use disorder, to use naloxone to reverse opioid overdoses, and to incorporate overdose prevention in your practice. Next slide. We will do this by first diving into drug-related overdoses, then talk about opioid use disorder treatment, and end with overdose prevention and reversal. Next slide. And as we get started, I wanted to share a little bit about how I ended up doing addiction medicine work as a hospitalist. I remember during my residency training, taking care of patient after patient with end-stage manifestations of their substance use disorder, people who came in with cellulitis and GI bleeding and heart failure. And I was very good at taking care of all of those things, but I rarely addressed the substance use disorder, if only to say, you need to stop using or you will die, you need to go to residential addiction treatment, because that's what I learned from my colleagues. And then it was really midway through my intern year when I admitted someone with alcohol-related hepatitis that things changed for me. I remember seeing this patient and being shocked at how sick she was. I got to know her really well over the 2-week hospitalization, and then even better as I took care of her in clinic and became her primary care doctor. I learned that she'd been drinking to cope with depression after a divorce. She had never had access to care, that she was hiding her ritual of vodka and orange juice from her mother and her young children. I got to know her mother, who accompanied her to appointments, as well as her ex-husband, and I saw all of the different barriers she faced to get care, and ultimately she passed away a few months later. And really caring for her and others like her since then has taught me that there are so many interventions that we can offer wherever we are in our medical practice to improve care for people with substance use disorders. And I'm here to share some of those with you in terms of opioid use disorder. Next slide. So let us start here. On this page, we have the number of deaths related to drug-related overdoses between 2018 and 2022. And what you can see on this slide is that we have reached an unprecedented number of drug-related deaths. Last year, over 107,000 people died of a drug-related overdose. Every year, we're hitting a new record. And you can see here in the green line that many of these drug-related overdoses involve fentanyl. And this is a big part of the story. Fentanyl is a very strong opioid, and the risk for overdose is high. Also, people are using these opioids that they're buying on the street, and the dose that they're using today, that somebody is using of fentanyl, may not be the same fentanyl they used yesterday because it's an unregulated drug supply. This is known as a toxic drug supply. And so even people who are using fentanyl regularly are at risk for overdose. The other thing that we are seeing happen is that people are unintentionally being exposed to opioids like fentanyl. We have people who are trying to use cocaine and people who are trying to use methamphetamine. And one recent study showed that 15% of powdered cocaine and methamphetamine had contained fentanyl. So this puts someone at risk for overdose when they have not been using opioids regularly. And I have definitely seen that in my practice where we're admitting people who had an unintentional overdose because they did not have a tolerance to opioids. We also know that the other thing that has fueled our drug overdose crisis is COVID. Think about the social isolation, the increased rates of depression and anxiety. Those are all drivers of substance use disorders. And so that is how we get to this moment in time where we have seen increasing numbers of drug-related overdoses. Next slide, please. And more locally here in California, we see that over 80% of drug-related overdoses involve fentanyl. And we are seeing so many people in our emergency departments, in primary care clinics, and in hospitals with complications of substance use disorders. Next slide. And then it's really important to think about how drug-related overdoses are affecting different communities. On this slide, we have drug-related overdoses between 2018 and 2022 by race and ethnicity. And you see a disproportionate effect of drug-related overdoses on American Indian and Alaska Native individuals, as well as Black individuals. And then when you come to white individuals, you do see that between 2021 and 2022, there was a slight decrease, which is wonderful. And then we see people who identify as more than one race and Latina individuals next, and then the lowest number among people who identify as Asian. And I think as we are thinking about the different things that are contributing to drug-related overdose deaths and the people being most affected, it's important to come up with solutions that are going to work for these communities, and important to have people with lived experience as part of our solutions. And also thinking about who our interventions are reaching and who they are excluding. For example, because we see this decreased number of drug-related overdoses among white individuals, I'm hopeful that we can also begin to see some of those trends among Black and American Indian and Alaska Native individuals. In San Francisco, where I practice, almost 3 people died of a drug-related overdose daily in August. And so those are some of the highest rates we have ever seen. Next slide. Now we're going to dive into how to, as clinicians, we can offer services to our patients and dive into opioid use disorder treatment. Next slide. And we're going to use a case to guide us through treatment. On this slide, I have a link to a QR code. This QR code links to a pocket card that you can find very helpful. The pocket card contains the Diagnostic Statistical Manual 5, DSM-5 criteria for a substance use disorder diagnosis, as well as some of the medications and resources that we will be discussing. Click again, please. So our case is that of a 35-year-old woman with right upper extremity cellulitis that you are seeing in whatever practice setting you work in, be that the emergency room, inpatient medicine, or an outpatient. Our patient shares that she smokes 2 grams of fentanyl per day, and she last used 16 hours ago. She started using at the age of 18. She shares that opioids help with the pain and trauma that she has experienced. You diagnosed her with opioid use disorder after you have a conversation with her. Click again. What opioid use disorder treatments do you offer your patient? Next slide. So as we talk about opioid use disorder treatments, medications for opioid use disorder, we think about what opioids are doing in a person's body. We have our mu receptor. That is where opioids, the opioids that people are using, bind. Opioids are full mu agonists. These include heroin, oxycodone, and fentanyl. Click again. The first evidence-based FDA-approved medication for opioid use disorder treatment is methadone. It is a full mu agonist. It works exactly like other opioids do. It's just long acting, and that's what gives it its special properties and why it works so well for opioid use disorder treatment. The second is buprenorphine. It's a partial mu agonist, and it has high affinity for this mu receptor. What that means is that when you give someone buprenorphine, if they have other opioids like heroin or oxycodone on there, buprenorphine is stickier. It will kick off the opioid that is on there and bind, but it has a lower affinity, it's a partial agonist, so it does not fully activate that receptor, which is why we worry about something called precipitated withdrawal, which I'll talk about in the next couple of slides. And the third FDA-approved medication for opioid use disorder is extended release naltrexone. This is a 30-day injectable medication. It's a full antagonist. It has very high affinity, again, for the mu receptor. So if you have opioids in there, it will kick them off and bind to it, and people will go into withdrawal. I won't be focusing as much on extended release naltrexone during our talk, and that's because it's often less preferred for many patients because they have to have a 7-day or more free opioid period in order to receive this medication. Next slide. When we're thinking about counseling our patients regarding methadone and buprenorphine and deciding between these two, it's really important to think about how people will access this medication. So for methadone in the United States, currently regulations require that people go to opioid treatment programs, also known as methadone clinics, to get methadone. This sometimes initially requires daily visits. Some of those regulations really loosened during COVID. So sometimes people can earn take homes even within a couple of days after being linked to a methadone clinic. But again, it will require early morning visits to a methadone clinic. And then buprenorphine is one that can be given in primary care. Some opioid treatment programs also carry it if people would like directly observed therapy. It comes in many different formulations. So sublingual for most of them, but there's also a monthly injectable that's really wonderful to be able to offer patients. In acute care, methadone can be given. So if somebody's being seen in the emergency department, they are a new methadone start or they need to continue their methadone, you can call the methadone clinic, confirm their dosing, or newly start them on methadone in the hospital and the emergency department. But at discharge, when they're leaving the emergency department or hospital, we cannot prescribe methadone. People have to be linked to a methadone clinic. In outpatient care, people have to be referred to an opioid treatment program to get their methadone. And then for buprenorphine, the X waiver is now gone. So any clinician with a DEA Schedule III license can prescribe buprenorphine. For methadone, one of the nice things about it is that people do not have to be in opioid withdrawal when you're starting it. It can be started anytime. And for buprenorphine, people do traditionally have to be in opioid withdrawal to start buprenorphine, or we have these new ways of starting buprenorphine, which are called low dose, microdose. There's a few other ways that you may hear them be referred to that don't require people to be in withdrawal. So this has really changed management, especially in the hospital setting. In terms of availability for methadone, it's important to know if you have an opioid treatment program nearby, because if you don't, it's not going to be accessible to your patients. And in some cases, the only option may be buprenorphine. And buprenorphine should be available. It's great to check with your local pharmacies to make sure they carry it. And I think beyond all of this, the most important thing is really what the patient wants, what will work for them and their body, because they know best. Also, methadone and buprenorphine make people feel very differently. Methadone has that full agonist effect. Patients have described it as feeling like a warm, fuzzy blanket. And buprenorphine can be more activating, very, very clear as people describe it. And in some people, it feels like a little bit anxiety provoking. And so they may, if they have underlying anxiety or something else, they may not prefer buprenorphine, they may prefer methadone. Next slide. The most important thing really about all of this is that we have so much to do in terms of closing the treatment gap. Currently in the United States, only 1 in 10 people is on opioid use disorder treatment. Click again, please. So we have a ways to go to help with this. And this is very important because medications like methadone and buprenorphine reduce all-cause mortality as well as overdose mortality by nearly 50%. And think about that. That's just one patient who is getting this benefit. We can all help by taking care of patients and ensuring that we are offering buprenorphine and or linking to methadone clinic when that is what they choose. Next slide. And so coming back to our patient, please click again. You counsel her on the differences between methadone and buprenorphine. Click again. And she chooses to start methadone because she is worried about precipitated withdrawal with buprenorphine and lives close to an opiate treatment program. You are in primary care clinic and you give her instructions to present at the OTP the next day. We do not have enough time today to go into the details of how methadone is started in emergency department and hospital settings, or what methadone clinics do when they're starting methadone, as well as how to start buprenorphine. There is some information about this in the pocket card, and you're also free to reach out to me, and I have some resources at the very end of the presentation that share how you can do these. And there's also a warm line that you will be able to call where we can really guide you in a step-by-step process. Next slide. So now let's end our presentation by focusing on what we can do for overdose prevention and how, as community members, we can reverse overdoses should we encounter one. Next slide. Click again, please. So in terms of thinking of overdose prevention, it's important to think about the education and the potentially supplies and medications that we can offer patients to reduce the risk of overdose. And this really focuses on a harm reduction based approach. And harm reduction is policies, practices that reduce the risk of, reduce the harms of drug use and promote health. And some of the things that you can share with patients are listed on this page. I'm going to focus on the ones in dark blue. These are some of the ones that I discuss most commonly with my patients. The first is the Never Use Alone phone line. This is a number that people can call when they are using drugs alone. And the reason that this is important is that one of the biggest risk factors for overdose is if someone is using alone. If they have a respiratory arrest, they cannot use naloxone on themselves. And so there's somebody on the other line. It's run by peers, it's free. People call, and if they stop responding, the peer on the other side of the line will be able to send, call 911 and send an ambulance. They also have a Spanish line that I've also included here, and there's a wonderful website you can refer to. It was recently featured in This American Life, so I encourage you to listen to that to learn more about Never Use Alone. One of the most effective things we can do is make sure that we have naloxone available for people, and we're going to go into details about what naloxone is and how we can use it, and just also remembering finally that people who are not only people who are using opioids, but people who are using stimulants and benzodiazepines also warrant overdose prevention education. And that again goes back to our toxic drug supply. People don't know what they're buying on the streets, and sometimes there may be some fentanyl included in these. And so they also need naloxone and they need overdose prevention education. Next slide. So naloxone is an opioid antagonist. It comes in many different formulations. You can see the spray version on this slide. It is now available over the counter, which is wonderful. And I'm really hoping that there will be more competition and the price will come down for naloxone. DHCS has an naloxone distribution project for some organizations, so you can see if you qualify and order some to make sure that you have it available. And I've listed the links to that at the bottom of the slide. Next slide. So thinking about when somebody has overdosed, some of the signs and symptoms, somebody who's not waking up despite verbal, and then if they're not waking up to verbal stimuli, to physical stimuli. You see that someone has shallow breathing or that they're really not breathing. They have blue, gray, or pale lips. They have cold or clammy skin, and they have pinpoint pupils. Next slide. And so when I'm walking around in San Francisco where I live, and I'm worried that somebody may have overdose, I stop, I approach someone on the street, and first I say, hey friend, are you okay? If people wake up, they're fine. They do not need naloxone. If they're not waking up, and I keep saying that, and then I approach them and I try to do some physical stimuli to try to wake them up and see if they respond to that. If they are still not responding, I then tell people, I give them sort of a verbal heads up, a verbal warning. I say, I'm going to give you Narcan. I'm going to Narcan you. Naloxone is also known as Narcan. And that often makes people wake up. They know what it's like to go into precipitated withdrawal. They do not want to experience that pain. It's very terrible. And if that happens, great, you're done. But if they're still not waking up, you insert the naloxone, depending on which version you're carrying. But if you're carrying the nasal one, you insert it into their nose and you administer it. And hopefully they wake up. If they wake up and they're walking around, they're arousable, you just tell them what you did. I also want to mention that when you give naloxone, you should move back because somebody is going to go into precipitated withdrawal, and if they wake up, they may wake up very agitated and uncomfortable, and so you want to move back just to make sure both of you are safe. If people are staying awake, no need to call 911. People are really afraid of calling 911, of potentially the criminal legal system responding. However, if they're not waking up and you have administered it, it's important to start thinking about rescue breaths. And if you don't feel comfortable with rescue breaths because you're out in the community walking, you don't have a mask, other supplies to administer rescue breaths. In some communities, people are endorsing starting CPR, calling 911. After 2 minutes after you've administered the naloxone, you can administer a second dose if you have one on hand or if anyone else has one on hand. Now, this was a very quick tutorial on how to use naloxone. There's also a wonderful San Francisco Department of Public Health training that you can access here. I've listed it on this slide, and as well as a National Harm Reduction Coalition DOPE project training. It's under a 10-minute video that you can watch that will go into more details. Next slide. So ending with really thinking about how California is responding to the overdose epidemic and our public health approach. One, we're making sure that we have good data to improve state and local level surveillance. It's important to know what's happening and where it's happening and who it's happening to so we can design effective interventions. Thinking about preventing substance use disorders, so looking at protective factors and reducing risk factors for substance use. And we know a lot of that starts early. So we really, while we're working on treatment, we also have to be working on prevention. Increasing public awareness and education with all hands on deck, ensuring that we expand naloxone access, that it's available everywhere and that people are educated on how to use it. and making sure that you carry some. And then as clinicians, we can offer evidence-based, effective, life-saving treatment that reduces mortality, like we talked about, by 50% and reduces stigma of substance use disorders. We can promote harm reduction and drug checking services. Next slide. And so there are so many different opportunities for us to improve addiction care. We just reviewed some of them. And then when you're seeing patients, you can diagnose them with an opioid use disorder and you can offer effective treatment. You can prescribe and carry naloxone, and you can link people to methadone clinic, or you can provide buprenorphine in your care and make sure they have follow-up depending on the practice setting where you're seeing your patients. Next slide. Here are a few different resources. The first is a substance use disorder warm line that I promised you. So you can call here. I think it's between 6 a.m. and 5 p.m. Pacific time, and people will guide you through how to start these medications or what to do, where you can send people to. The California Bridge program also has a lot of different resources on there. You can check out the SAMHSA website for where your local methadone clinics are. Make sure you have naloxone. Make sure you have training on naloxone. And then I've included the pocket card and the QR link again at the very bottom of this page. And next slide. And then you're free to contact me for any questions, or if you have questions about how to become addiction medicine board certified, the practice pathway is available through 2025. Thank you.
Dr. Martin, thank you so much for that incredibly juicy, if brief, introduction to how we can all help in this incredible epidemic. Sorry, we still have Dr. Pan's name on here, but I'm going to invite James Watt back so that we can ask a few questions. We did have plenty of questions. So I would love to start with you, James. We got a couple of people asking the specific question of how long they should wait after getting the last COVID vaccine before they get the new one. So if they just got boosted in September, when should they get the next one?
2 months.
2 months.
And we are recommending that folks get the new vaccine because it is better matched to the strains that we're seeing right now, which are pretty much all XBB subvariants circulating.
Okay, great. Super helpful. Lots of questions, as you can imagine, about the issues of opioid use disorder, so I'll dive in on some of those. One participant asked, do we have any stats on what we think the number of lives saved in California have been with Narcan? Or I don't know that we have a way to do that, but has anyone done that research?
I think different communities have stats, like in San Francisco, when people get naloxone, they're asked to report if they used it and administered it. And some of the community-based organizations are definitely keeping track of this. It's required as part of reporting. But I don't know that we have one for California-wide, so that'd be really wonderful.
Great. People are asking about the availability of these reversal meds, of Narcan in particular. So we know it's available over the counter. Do we have a sense, is it widely available? Do pharmacies have lots of stocks? And then the question is, what you alluded to, hopefully the fact that the cost will come down, but do you know how much it costs now?
Yes, one of the ways that you can get it too is you can actually just go to your pharmacy and get it without a prescription, and it should be covered by your plan. So that's one way to get it. And then the other way is to buy it over the counter. And I think costs vary, so I won't go into those details. But the other thing that you can do is partner with your local community-based organizations, make sure that patients and people who are around people who use drugs specifically have it available so that it's in all the hands that it needs to be.
Great, amazing. And it feels like the naloxone distribution project is a very important project, but maybe, I don't know if there's a sense of whether it's well used or underused, or there are organizations who could be, as you described, community organizations that could be accessing Narcan, and we just need to help advocate them to go get it from this free state program. That may be a way that we as clinicians can partner with local organizations. one question, you sort of had that arc of what the state is doing to help us with opioid use disorder and saving more lives. And so one speaker said, well, why isn't naloxone distributed to the public more for free? So Marlene, I don't expect you to have the answer. James, I don't know if you have much experience in this world at the state level, but if you have comments, then please do.
So the community-based organizations do distribute it for free. This has been a big effort led by people who use drugs, people in recovery for a while before a lot of us got involved in this. And I think having it, especially in the hands of people who use drugs, who are around other people who are using drugs so that it's there and available if somebody overdoses is so important. And so that's why community-based organizations as trusted resources have had this available. But then I think now as community members, we're trying to also get it into the hands of other people who may witness an overdose, may pass by somebody who overdosed. And I think that is where we have some work to do.
Mm-hmm. And how about buprenorphine? You said that naloxone is covered by insurance. Is buprenorphine widely covered by insurance, both commercial, Medicaid, and Medicare? Do you have a sense of how good that coverage is? Is that a problem for any of your patients or other patients?
In California, we have great coverage. Medicaid covers it. So that has been awesome to see.
Mm-hmm. Great. And do you have a sense of commercial insurance programs? If a person who has opioid use disorder is not Medicaid eligible, is this easy to get? I don't know if you have a sense of that.
I do take care of patients who have private insurance sometimes, and it has generally been covered. Sometimes what is not covered for people who have private insurance or is more difficult to find coverage for are the behavioral interventions such as residential addiction treatment. But with the medications in California, I have not found that to be the case. In other states, and this may have changed now, but when I last looked, sometimes there were boundaries set on what dose of buprenorphine you could prescribe. Insurance wouldn't cover beyond a certain dose. I think a lot of that has changed in the last couple of years, and people have a lot more access to it.
Great. You talked, Marlene, about extended release naltrexone. What about, one of our participants was asking about extended release buprenorphine, and just wondered if you have a comment about the use of that.
Yes, we use extended release buprenorphine very often. It's a 30-day injectable version of the buprenorphine. I work in the hospital setting, and once we get people on a buprenorphine dose that is adequate and they want the injection, we actually administer it in the hospital, and our clinics in San Francisco are also offering and administering it. And the version we've had, Sublocade, has been used for quite a while, and there's a new FDA-approved version of the injection, Verdaxi, I believe it's called, that should be widely available soon. I think it just needs to be added to the Medicaid formulary. So great opportunity to expand access to injectable buprenorphine. It stays in the system for 30 days or more, so it's protective against overdose.
Great. For those of you who don't know, the governor has just signed a bill, and as I'm a pediatrician, I have my eyes on this, which is AB 816, and that permits physicians to enroll youth over the age of 16 in buprenorphine treatment without prior parental consent. But we know there's growing epidemic of youth opioid use in California. So Marlene, do you have guidance for treating pediatric patients with opioid use disorder? And what's the youngest age that Narcan nasal spray can be used as a rescue medicine? So sort of two questions there.
We know that naloxone will work because of its mechanism, no matter the age of someone. And so if you suspect an opiate overdose among somebody who's not over the age of 18, it's okay to use naloxone and administer that and hopefully save that child or person's life. And then in terms of my experience taking care of people in the pediatrics age group with substance use disorders, we sometimes, where I work, see sporadically patients with an opioid use disorder. And, it does involve parental consent when somebody is at that age. And we have been able to work with our patient and their parents to get people on buprenorphine.
Okay, great. And we just had a question about whether neonates have the same withdrawal with the med used to treat opioid use disorder as the opioids themselves. And so is that a concern in the neonatal setting? I recognize that's not your expertise, but tell us what you know.
Yeah, I do take care of a lot of pregnant people and people who have recently delivered. And I think the most important thing that I can say is that when somebody has an opioid use disorder, you offer this evidence-based life-saving treatment. Methadone and buprenorphine are very safe during pregnancy, post-pregnancy. It is so much better than somebody being intermittently in withdrawal, and not having anyone experience any kind of withdrawal, because that is very stressful. And then in terms of when postpartum, when the baby is born, we have so many effective ways to manage neonatal opioid withdrawal syndrome should it happen. A lot of those interventions actually don't always require morphine to be administered. There's a lot of other things that we do, and the babies do very well after with lots of monitoring and lots of interventions like skin-to-skin contact, parent being there, staff being there to support the baby after birth.
Great. So many questions on opioid use disorder, so I'm ignoring you a little, James, but I'm going to pivot back to you for two questions. One is, do you have any information on the influenza vaccine this year? What strains it's focused on, and how influenza is looking like in other countries as it comes towards us?
Yeah, so far everything seems to be as expected. Don't have a lot of information about, we haven't seen any influenza here yet, so really can't comment on the match here, but I think alignment with what we're seeing in other countries looks good.
Great. And people are always wondering about new COVID variants. Any COVID variants on the radar that you're looking at hard and worried about?
Yeah, it's a great question, and COVID is so ever-changing. It's hard to keep track of it all. What I can say is that right now we're seeing kind of a mix of different XBB substrains. Nothing is really dominating. Nothing's sort of going up really fast. It's been pretty steady in that way. A couple of things have come up globally that people have looked at with a lot of different mutations. One is BA.2.86. That one has been identified in California, but we haven't seen it. We've just seen it a couple of isolations, and it's not really registering in terms of an increase overall. So we're monitoring that one, but not seeing it as a big issue right now.
Great, thank you. Back to you, Marlene. A lot of our participants today are really thinking hard, I think, about how we create system changes that will improve our ability to treat folks with opioid use disorder. I know we're all just seeing this everywhere in our own communities. So one question was, do you have any advice on how to implement medically matched treat clinics for homeless patients via mobile street medicine program? And do we have experience with that particular method of treatment in San Francisco that you know about, or any other comments?
Yes, that's a wonderful question. I think I said that during my presentation, the thing about we need all hands on deck to meet people where they are and offer evidence-based treatment. In San Francisco, we have our street medicine team. We have Maria X. Martinez Clinic that are drop-in centers, and then our street medicine clinicians and staff who are out there in the community offering services to patients. So we do have different examples of that. I know LA County also has other examples. I know Contra Costa County has an EMS system that I believe is offering buprenorphine also. So there's just so many different examples of systems, lenses, interventions to approach our overdose epidemic.
Great, that's helpful. It sounds like those might be places for people interested in starting this in their own community to reach out to get the experience of others who have done it. Another sort of similar question was, how do we make it easier for people who've been administered Narcan or buprenorphine by EMS to follow up into medically assisted treatment care? What are those pathways like?
Yeah, so if EMS is administering naloxone or buprenorphine, I think it's important to make sure you have that linkage point. I think about that a lot in the hospital setting where one moment in time, people are not coming to the hospital because they want opioid use disorder or any other substance use disorder treatment. They're coming because of that medical illness that brought them. They're not the ones calling EMS, right? And so thinking about how we can really approach people with compassion, without stigma, and to give them the resources that they are open to, and not make it sort of an ask or a requirement, and just share, like, we have this drop-in clinic, make it as easy as possible. Low threshold clinics have this available not only in specialty addiction clinics and buprenorphine clinics, bridge clinics, but all over primary care and street medicine. In hospitals, I think there's a big need. I'm biased and I work in a hospital, but there's a big need to ensure that addiction services are available in hospital settings.
Great. And I guess, one other question was, how do I get my colleagues to be more willing to prescribe medically assisted treatment? And I think that, hopefully it's educational opportunities like this. It's people who know how to do this, talking about it. It's once you learn about it, then teach, see one, do one, teach one, as we all learned in medical school. But I just wonder, what is your sense of willingness among physicians, over the last 5 years or decade even, to really engage and learn and do this kind of treatment in many settings, not only in the hospital, but also in primary care settings as well?
People identify some of the barriers to treatment as not knowing how to use these medications. I can speak for myself when I share that I did not learn this in medical school and I did not learn it in residency. It was myself seeking out all the different resources, and that is changing now. So I think, one, making it part of medical education, identifying addiction as a chronic medical disease that has treatment and that recovery is possible, because with substance use and with mental health, stigma is a big barrier to treatment. We ourselves have our own perceptions of, why is that person potentially not strong enough? That's sometimes what I hear, to just quit on their own. This is not something I should be treating. I am replacing one drug with another drug that I'm giving them. But no, I think I'm thinking about an addiction as a chronic medical disease with negative consequences. When people are on methadone or buprenorphine, those consequences, that DSM criteria that they're meeting, a lot of those things go away, and they can be in recovery, they can be promoting their health and engaging in care. And I think it's just change hearts, change minds, use data. When you do this and start someone on treatment, share those stories with your colleagues, and that's how over time we'll get everyone there. And then I think we do need policy and interventions at systems levels, maybe at the state level, at healthcare system levels, that really state that you need to treat this, that you can't just ignore it, that you can't not have methadone available on formulary to get everyone on board. Because I think people who may be a little bit hesitant to offer these medications, they just need some support. And in our own hospital, the addiction care team has helped provide that support for people. But I think people are just looking for a little bit of help.
Yeah, that's helpful. And you had that great slide that shows sort of the different levels of deaths from opioid use in different populations in our state in particular. Do you have any wisdom or pearls about particular needs that different populations have, ways that we as providers can help meet people where they are, whether they're from the Latino population, they're African American, et cetera?
Yes, great question for this. It is so important to check in with your patients and find out what their priorities are and what they think they need. I think the people who use substances, who use drugs, their lived experience and the lived experience of others from that community is invaluable and really needs to be centered. And they need to be a part of the solution as we're thinking about all of these. With the Latina population, for example, one of the things I'm working on for the UCSF Latinx Center of Excellence is this program that the California Healthcare Foundation just funded, where we are co-designing a program in education for drugs and alcohol for Latina. So we are partnering with a few different community-based organizations that have Spanish-speaking community health workers, and we are training them in how to recognize unhealthy substance use, how to discuss this, how to communicate with the community, and then how to refer people to the different resources that are available, because they're trusted resources. And I think going back to the point I mentioned earlier about we need to prevent addiction, and we do not only need to focus on the treatment part. And so I really, for myself as working within the hospital walls, I really want to think about how we can start to work beyond that and partner with community organizations.
Amazing. It looks like we have time for a couple more questions. They keep coming in. Can you comment on how long you need to observe a patient who has been revived by Narcan for possible rebound, particularly if the opiate was long versus short acting?
Yeah, I think if they're waking up and they're walking around, I think you're, just check in with them, ask them if they need additional support, if they want you to call anyone. And if they're like falling back asleep, I think staying there, just checking in with them, trying to like wake them up. And, if you're constantly having to move them to keep them awake, I think it's just important to have extra support there and tell them that you're going to call 911, and then keep them, doing physical stimuli to try to keep them awake and breathing, or if you need to do rescue breathing or chest compressions while EMS arrives.
Great. How do you happen to know about the availability of treatment, naloxone in particular, on commercial flights?
I think they have. I believe that that commercial flights have naloxone available. I always carry mine too when I'm flying, just to have that.
Certainly seems like a good reason to do that. And how about schools? Do we have a sense in California of availability of treatment in high schools and universities?
Yeah, there has been a call to have naloxone as widely available as possible in schools, in bars and other places, in dance halls. And I think there's also a lot of community buy-in that we need when we're doing that. And I'm not sure exactly what the status is right now.
Yeah. Great. Well, I do believe that that's all the time we have for questions today. So I really want to thank you both for being here today to present today's content. And thanks everyone for listening in, both for being here today, but please do forward this webinar information to your colleagues. It will be available online in video form at our website, covidroundsca.org. Even though we're doing public health now, we still have that web URL. And just as a reminder, you'll receive the survey around 5 p.m. today, and you can attest your attendance to get CME. And I want to alert you all that our next session will be on Tuesday, November 12th. We'll have a really exciting talk about a topic that is increasingly relevant in California that I hadn't thought about since medical school, which is silicosis. So please join us for that. Thank you again, everyone, and have a great afternoon.
Thank you.